This was a lady from China who had been diagnosed with presumed lung cancer in China, and she was being treated as such. She had received 2 courses of chemotherapy at a hospital in Beijing for the treatment of metastatic lung cancer. She decided to seek an opinion here at Johns Hopkins, and that's why we reviewed her case along with colleagues. And in reviewing the case, there were a couple of things that stood out. Her scans were not entirely consistent with lung cancer. She had lymph nodes in the abdomen, which we usually don't see with lung cancer. And also, some of the findings when the sample of tumor was examined were more suggestive of another primary site, perhaps in the colon. So we then explored things further and arranged a PET scan here in the United States, and that PET scan suggested she did indeed have lymph nodes in the abdomen and a mass in the colon and the bowel. So putting everything together at that point strongly raised the question, was this really a colon cancer as opposed to a lung cancer? The
thoracic oncology group contacted me, and we reviewed her images with our GI tumor board, our gastrointestinal cancer tumor board, and in a large collaborative group involving medical oncology, radiation oncology, and GI surgery. We all sort of agreed that the pattern didn't make sense for primary lung cancer that had spread to the abdomen. I saw the patient urgently the next several days later and got her set up for a laparoscopy, which is about, every institution has their own protocols, but here it takes about half hour to an hour in the operating room under general anesthesia, and using just 3 small incisions, about 5 millimeters each. We were able to put the camera in and easily find this para-aortic lymph node. We were able to excise it in full and brought it to pathology, where on frozen section analysis they felt it was consistent with colon cancer, but needed more time with immunostains to be sure. The patient recovered, went back to her hotel uneventfully the same day, and then we brought her back to clinic the next week when we had the immunostains that confirmed that this was metastatic colon cancer. We discussed her case in tumor board, set her up to see a GI oncologist here, Dr. Katie Bever, and Dr. Bever saw her shortly thereafter with a colonoscopy by one of our GI doctors, and there we diagnosed metastatic colon cancer.
Unfortunately, this additional workup confirmed that she had metastatic colorectal cancer, which we manage primarily with chemotherapy. So I recommended that she get chemotherapy, which is our standard first line for metastatic disease. And additionally, a biologic agent could be added based on her molecular testing that she had done previously.
Multidisciplinary care, particularly for locally advanced or metastatic cancers, is critical for making sure that we have the right diagnosis and that we've sought all avenues of treatment, whether it's chemotherapy, radiation, surgery, or other therapies. It's vital to have all stakeholders at the table and to discuss this in a thorough fashion.